And this is the fourth part of our series discussing hemodynamic implications in patients with tricuspid regurgitation-related right heart failure. And here we're now going to take a look at prognosis after tricuspid interventions. The goal is to recall data supporting the prognostic benefit of TR reduction, to illustrate the prognostic value of hemodynamic factors, and to understand the importance of central venous congestion. The fact that tricuspid regurgitation might be a treatment target and tricuspid interventions a valuable treatment option to reduce rates of mortality and heart failure hospitalization has been suggested by early observations showing that patients with successful reduction of TR through the intervention had significantly improved outcomes as compared to patients without TR reduction. This was also true when compared to medically treated patients in matched cohort analysis, and is translated into a reduction of heart failure hospitalization rates within individual patients. The first randomized controlled trial in the field demonstrated safety and efficacy of tricuspid edge-to-edge repair to not only reduce TR, but also significantly improve quality of life. However, there was no effect on mortality or heart failure hospitalization. Different lines of argumentation have been brought forward as to why that was the case. One of them is that the mortality rates in the trial were much lower than described before in these patient groups. And this has been attributed to much higher rates of left-sided valvular heart disease in prior observational studies, here illustrated in blue. That the underlying disease might actually influence the prognosis of patients undergoing tricuspid interventions can also be appreciated when comparing different phenotypes of left heart failure. Patients with heart failure and reduced ejection fraction seem to have an overall higher rate of mortality and heart failure hospitalization as compared to patients with heart failure and preserved ejection fraction. Conversely, patients with HFpEF seem to derive a greater prognostic benefit from the intervention when compared to medically treated match control cohorts. What about right heart function? We observed that TAPSE offers limited prognostic information after tricuspid intervention, and this is probably due to the fact that it purely reflects longitudinal function. When STR-related right heart failure progresses, contractile patterns shift and the longitudinal RV function is diminished. This is initially compensated for by an increase in circumferential function here in the middle. And only when this compensatory mechanism fails, we observe global RV dysfunction, which manifests with a low RV ejection fraction and then is prognostically relevant. Pulmonary hypertension is associated with adverse outcomes after tricuspid interventions. However, there's some heterogeneity with patients that have a discordance between invasive and echocardiographic pulmonary hypertension assessment having the worst outcomes here. It's important to thoroughly characterize pulmonary hypertension, and this includes the assessment of markers of precapillary disease, such as transpulmonary gradient here, TPG, or pulmonary vascular resistance, both of which are indicative of an adverse prognosis. However, it's important to note that all of these prognostic markers identify patients at higher baseline risk, and the fact that also high-risk patients, like here, improve symptomatically, and the fact that we lack dedicated comparison trials currently precludes conclusion on futility in these patients. All right, now we've looked at RV function and RV afterload, and we're ready to combine it, giving the implications right ventricular loading and tricuspid intervention. The integration is appealing and can be assessed with RVPA coupling as discussed before. So non-invasively, this can be realized by estimation of the ratio of TAPSE over PA systolic pressures derived from echocardiography, and this allows for a nice risk stratification. This prognostic value can further be increased by incorporating invasively diagnosed pulmonary artery pressures instead of echocardiographically derived pressures, which with consistent cutoff values for both methods across studies. However, the overall predictive value is still limited. When you have a look here down to the right, there's an area under the curve for mortality prediction of 0.63. Consistent with what I just showed you early, consistent with what I just showed you, early hemodynamic studies showed a prognostic value of PA pressures, markers of precapillary disease, of pulmonary hypertension, and RV stroke group. But interestingly, there was no association of prognosis with pulmonary capillary wedge pressures, RA pressures, or cardiac output. So why should central venous pressures not be related with prognosis in patients with right heart failure? In patients with tricuspid regurgitation, RA pressure actually is a therapeutic target. And as you treat tricuspid regurgitation, you might want to bring down the V wave and reduce RA pressures. And when you quantify this, you see that you get a slight decrease of mean RA pressures, a little bit better in the V wave, but importantly, up to 1/5 of patients do not experience a reduction in RA pressures after therapy. So there's quite some heterogeneity here too. In addition, we found an interaction with the baseline cardiac output in patients undergoing interventional TR therapies. In fact, there appears to be a U-shaped relationship of cardiac output with mortality, and somewhat counterintuitively, the highest mortality rate here in patients with a relatively high cardiac output. Especially in these patients, RA pressures could not be reduced through tricuspid regurgitation intervention, despite a reduction in regurgitant volume. Therefore, we postulated the existence of a hypercirculatory TR phenotype characterized by chronic renal and liver congestion, sympathetic overactivation, decreased venous capacitance, high levels of stress blood volume, and overall a limited hemodynamic benefit in response to tricuspid interventions, and persisting signs of right heart failure, and overall an impaired prognosis. Functional volume distribution in the body has an important role in regulating hemodynamics. Total blood volume is divided between unstressed blood volume, which actually fills the vascular space, and stressed blood volume, which creates intravascular pressure. And stressed blood volume can be recruited from the splanchnic venous system upon sympathetic nervous activation and or venous constriction. And to further elucidate its role, we model stress blood volume using invasive hemodynamic data in patients undergoing tricuspid intervention. And indeed, we found that patients with elevated levels of stress blood volume experience less reduction in RA pressure, despite effective reduction in tricuspid regurgitation, which was also associated with persisting symptoms of right heart failure and an impaired prognosis. And clinically, this might be approximated by the assessment of congestion patterns according to the elevations of right atrial or pulmonary capillary wedge pressures, as summarized here on the slide, and appreciate a gradual increase of levels of stress blood volume from the euvolemic pattern to the bilateral congestion pattern, and notably congestion pattern involving RA pressure elevations had the worst outcomes. So in conclusion, transcatheter tricuspid interventions improve quality of life with TR-related right heart failure patients. And prognostic implications in terms of mortality and hospitalization have been suggested by registry data and match comparisons. A number of hemodynamic indices convey prognostic information, but the use for patient selection is currently limited. Central venous congestions prior to and post tricuspid intervention does have prognostic and functional implications. And with that, thank you and hope to see you in the next video.